Good morning, afternoon, and evening, everyone. Thank you for joining us today for the webinar titled Micronutrient Status of Women and Young Children in the Hashemite Kingdom of Jordan. I am Dr. Shabani Ghosh. I am the Principal Investigator for the Jordan Nutrition Innovation Lab. And as more attendees are joining the webinar, I will begin by going over some of the logistical items. Next, please. I would like to direct all attendees to a few functions on the Zoom call. At the bottom of your screen, you should see a chat icon and a Q&A icon. Please use the chat feature to engage in relevant conversation with the other attendees. Next, please. You will also find a Q&A feature, and for this webinar, we would like you to use the Q&A feature for asking questions to one of the panelists. We have allocated the final 20 minutes of this webinar for Q&A, at which point the panelists will respond to any questions from the audience. The likelihood is that we will have some online responses, so do please pay attention to the Q&A box, as some questions might be answered online. If you are experiencing any technical difficulties, please send us a message in the chat to all panelists so that our technical support staff can assist you. This webinar is being recorded and will be made available on our website following the event. Next slide, please. Before I introduce you to today's moderator, let me introduce you to the Jordan Nutrition Innovation Lab, a research and capacity building program that is funded by USAID Jordan. We pursue research and capacity building activities to support the health and nutrition of women of reproductive age, pregnant and lactating women, infants, and young children in Jordan. Our key objectives are implementing a rigorous maternal and child nutrition research agenda, including conducting secondary analysis using existing nationally representative data, conducting comprehensive evaluations, such as the one that we are implementing in collaboration with USAID's Community and Health and Nutrition Program, and building individual and institutional capacity through the award of fellowships, conduct of scientific symposia, workshop, and webinars. As part of a capacity building agenda, we have recently successfully implemented the first national symposium on maternal and infant nutrition under the patronage of His Excellency Professor Dr. Firas Al-Hawari and the Ministry of Health. In this past year, we've also awarded research fellowships to 2 researchers in Jordan and have implemented a 1-week short course on research methods. In addition to these, we conduct these webinars on a regular basis as a means to conducting outreach to a wider stakeholder group in and outside Jordan. Today, we are convening to listen to esteemed speakers from Jordan in what is the 3rd webinar of this year. Let me go over to the webinar. This webinar is being moderated by Haneen Abulela, who is the country coordinator for the Jordan Nutrition Innovation Lab. Haneen has over 15 years of experience in project management and implementation and is currently overseeing both the research and the capacity building components of JNIL. Her accomplishments on this project further include developing the knowledge and skills of stakeholders in the maternal and child health and nutrition landscape in country. Prior to working with JNL, Haneen was a project manager at MedAir, where she strategically planned and led the implementation of interventions that sought to improve maternal access to healthcare and nutritional knowledge, as well as maximize healthy behaviors. Haneen is a graduate from the University of Jordan with a degree in pharmacy. With that, I'm going to hand it over to you, Haneen, to take over the webinar. Thank you, everyone, for joining, and I hope you will enjoy what we have as a fabulous planned session. Over to you, Haneen.
Yes, thank you very much, Shibani. Good evening, everyone. It's my pleasure to welcome everyone to the Jordan Nutrition Innovation Lab's 3rd webinar, titled Micronutrient Status of Women and Young Children in the Hashemite Kingdom of Jordan. Jordan has witnessed a sustained economic growth and the nutrition transition in the last few decades. Despite the progress, reduction in the prevalence of micronutrients deficiencies have been mixed. under the auspices of the Ministry of Health and key stakeholders in Jordan. The Jordan National Micronutrient Survey was implemented in 2019 to provide a comprehensive assessment of various forms of malnutrition and its associated factors, and to assess the prevalence of deficiencies of key micronutrients like iron, vitamin A, vitamin D, and zinc in women of reproductive age and preschool children. Distinguished panelists in this webinar will present findings on the trends of the micronutrient status, as well as the nutritional status and food consumption patterns of reproductive age group women and young children in Jordan. Our first esteemed speaker is Engineer Rawhiya. Engineer Rawhiya is the head of the nutrition department at the Non-Communicable Diseases Directorate at Ministry of Health in Jordan. She is responsible for improving the health and well-being of Jordanians through monitoring and evaluation of nutrition strategies, including food fortification and supplementation programs. She has developed and promoted food-based dietary guidelines and non-communicable diseases management guidelines, and has led national studies for the assessment of micronutrients deficiencies and impact of fortification programs on health status among women and children and childbearing age and children under 5. Engineer Rawhiya has published many recent scientific papers, including the review of the nutrition situation in Jordan, trends and way forwards. She also provides nutrition assistance, dietary guidance, nutrition policy coordination, and nutrition education for Jordanians and Syrian refugees in collaboration with UNICEF and WFP in Jordan. A certificate of appreciation has been awarded to Engineer Rawhiya, acknowledging her significant and excellent work with the nutrition unit at WHO in the Eastern Mediterranean region, as well as for her leadership of the nutrition program in Jordan. Engineer Rawhiya, the floor is yours.
Hi, everybody. First of all, I would like to thank the organizer of this webinar and give me the second opportunity to share the experience of Jordan for the nutritional strategies and program in improving nutrition status of the Jordanian population, mainly for the children under 5 years and women in childbearing age. Next, please. To decrease the micronutrient deficiency levels, Jordan has undertaken 2 national micronutrient fortification programs, a national salt iodization program and wheat flour fortification program. Because of a high goiter rates observed in 1990s, the Jordan government has initiated a salt iodization program in 1995, rendering the iodization of salt for human consumption mandatory. And shortly thereafter, Jordan joined the iodine deficiency disorder control program in 1996. This led to establishment of a monitoring and evaluation program in 2000, succeeding implementing an effective national iodization program, including coverage of legislation, regulations, political commitment, and national program committee, as well regular monitoring procedures, mandatory reporting, public education, and social mobilization. Surveys conducted in 2002 and 2010 found a consistent improvement of iodine nutrition in school-age children, where the prevalence of goiter was in 2002 33%, dropped to 4.9% in 2010. Accordingly, this was followed by an adjustment of mandated iodine levels down from 50 part per million to 20 to 40 part per million. Next, please. Next, please. No, there's a slide before that. Yeah. To tackle the burden of additional micronutrient deficiencies, the Ministry of Health initiated a flour fortification program in June of 2002, rendering the addition of iron and folic acid. Iron was added by 30 parts per million of iron and 1.5 parts per million of folic acid to موحد wheat flour mandatory. This type of wheat flour constitute about 90-30% of the total production of the mills in Jordan and highly consumed by the Jordanian population. In 2002, monitoring and evaluation program was started as well. Later in 2006, the program was expanded by adding vitamin A, B1, B2, B3, B6, as well, B12, and zinc to the premix. And also the level of iron in the form of dried ferrous sulfate was increased slightly to 32 parts per million, and folic acid was reduced to 1 part per million. An impact assessment comparing the 2010 with the 2002 National Micronutrient Survey result found mixed results with decline in the prevalence of iron deficiency and iron deficiency anemia in children, but not in women. However, based on the result from the 2010 survey, which showed a very high prevalence of vitamin D deficiency, accordingly, vitamin D was additionally included in the wheat flour premix. Next, please. The 2000 National Baseline Assessment Survey of Iron Deficiency Anemia and Vitamin A revealed that the prevalence of vitamin A deficiency among the children was 15%. So to address the sequel of vitamin A deficiency in children, vitamin A supplementation of 100,000 international units is recommended for the infant along with the measles vaccine in 2005. As well, based on the result of 2010 National Micronutrient Survey, which revealed that vitamin A deficiency is a public health problem of a moderate importance in children, where the prevalence was 18.3%, while it was a severe public health problem in the North region. The National Higher Committee of Nutrition, chaired by His Excellency Minister of Health, recommended a routine vitamin A supplementation of 200,000 international units recommended for the children at 18 months of age in 2012. Next, please. So the objectives is to assess trend for key micronutrient indicators for the preschool children and women in childbearing age in 2010 compared with the 2019. Estimate the prevalence of acute malnutrition, wasting using weight for height, chronic malnutrition stunting using height for age, underweight using weight for age, and overweight and obesity using body mass index for age in preschool children. As well, estimate the prevalence of chronic energy deficiency and overweight and obesity in a non-pregnant woman by calculating the body mass index. Provide an update estimate of the coverage of adequately fortified bread in a household in Jordan. Next, please. So for ensuring a comparability of 2010 with the 2019 surveys, only data from the settled population from the Jordan National Micronutrient and Nutrition Status Survey 2019 was used. The age range for the preschool children was restricted to 12 to 59 months because no children younger than 12 months were included in the 2010 survey. No adjustment for the inflammation was done for ferritin or retinol binding protein values because this was not done in 2010. Red blood cell folate, not serum folate, was used for the folate deficiency comparison. To define the fortified bread in 2019 survey, a cut of 15 parts per million was used to replicate as closely as possible the iron spot test used in 2010 surveys. This threshold was determined to yield decent sensitivity compared to the quantitative measurement in 2019 survey. Next, please. So for the finding of the key results between 2010 and 2019 for the settled population, the indicator is the coverage of the fortified bread at a household level. In 2010, survey revealed that the fortified bread at any level of the fortification was 44%, while in 2019 it was increased to 83.8%, and the adequately fortified bread by fortified bread is the main fortified bread is 50.5% in 2010, while it increased for 83.3% in 2019. Next, please. As well, for the comparison of the key result for the preschool children from 12 to 59 months, regarding the anemia, there was a significant improvement in the prevalence of anemia. In 2019, it was a drop from 60.8% to 11% almost. And there's increase in the iron deficiency in 2019 by 20.4%, comparing with the 2010 3.7. As well, there's a slight decrease in the prevalence of iron deficiency anemia into 2019. For the vitamin A deficiency, which is really the, or indeed the target of the Ministry of Health to evaluate as well the vitamin A supplementation program, was a significant improvement in the prevalence of vitamin A deficiency. It was dropped to 7.4% from 80.2%. For vitamin D deficiency, there's an increase in the prevalence of the vitamin D to 22.9%. For the malnutrition indicators, there was a significant improvement in the malnutrition status for the preschool children. Underweight was decreased to the half, 1.5% from 2.56. As well, for stunting, it decreased to 6.3% from 11.7%. Wasting, actually, Jordan is considered one of the country of the EMRO region with a low prevalence of wasting, which is normal public health problem. For the overweight and obesity, it's remain the same with no changes. Next, please. Yeah, for the non-pregnant woman from 15 to 49 years, the anemia is decreased from 30.6% to 25%, while there was an increasement in the prevalence of iron deficiency for 50.4% from 35%. And iron deficiency, there's no changes, and vitamin A deficiency is slightly decreased. Vitamin D deficiency is remained the same. Folate deficiency and vitamin B12 deficiency is increased slightly. Next, please. Yeah. Summary of key findings of a Jordan National Micronutrient and nutrition status, including assessment of the temporal trends and of a public health relevance. The temporal trends are compared against the 2010 National Micronutrient Survey using the 2010 data analysis approach. However, unless otherwise noted, the prevalence estimates presented are those obtained through the 2019 analytical approach. For the first indicator, fortified bread more than or equal 15 parts per million, there was an increase in the consumption of the fortified bread at a household level. For the other indicators regarding anemia in the preschool children, There's the increase in the prevalence of anemia, and it is considered, according to the WHO classification, a mild public health problem. Iron deficiency anemia is increased. Iron deficiency, decrease. Iron deficiency anemia remain no change. Vitamin A deficiency is decrease, and it's a mild public health problem. For vitamin D deficiency, it's remain with no changes. Zinc deficiency is a mild public health problem with a prevalence of 12%. For the malnutrition indicators, stunting is decreased, and it is considered as a mild public health problem. For the wasting is considered as a normal. Overweight and obesity is there's no change, and it is considered as well a mild public health problem. For these indicators in the non-pregnant woman, for the anemia, there's a decrease in the prevalence of anemia, and it's a moderate public health problem. For the iron deficiency, there's increase by 66%, while for the iron deficiency anemia, it's remain with no change. And for the vitamin A deficiency, it's remain constant without any change, with a prevalence of 3%. As well for the vitamin D deficiency, no changes. For folate deficiency and the vitamin B12 deficiency, there's increase in the prevalence of these two indicators. For the underweight, the prevalence was 5%. Regarding the overweight and obesity, it's considered as a severe public health problem with a prevalence of 60%. Next, please. Yeah. The conclusion with regards to anemia, there has been a decrease in the prevalence in the Jordanian population in the past decade since the 2010 National Micronutrient Survey. The prevalence of anemia in children from 12 to 59 months decreased by 6 percentage points. However, the prevalence of iron deficiency increased by about 7 percentage points. The prevalence of iron deficiency anemia remained largely unchanged. The prevalence of vitamin A deficiency decreased, but the prevalence of vitamin D deficiency increased, albeit without statistical significance. The prevalence of stunting and wasting in the children decreased over this time period, while the prevalence of child underweight, overweight, and obesity remains largely unchanged. So the conclusion that the change in vitamin A deficiency in the preschool children from 2010 to 2019 may be attributable to the implementation of Jordan's vitamin A supplementation program and changes in dietary patterns over the past decades. Next, please. For the non-pregnant woman from 15 to 49 years of age show a decline in the prevalence of anemia and increase in the prevalence of iron deficiency, and a little change in the prevalence of iron deficiency anemia between 2010 and 2019. The prevalence of deficiencies vitamin A and D remained largely the same. On the other hand, the prevalence of both folate and vitamin B12 deficiency increased substantially during this time period. No anthropometric measurement on a non-pregnant woman were conducted in 2010, and thus no comparison could be done. So the decline in anemia prevalence since 2010 may be attributable to some extent to Jordan's wheat flour fortification program, and further research is needed to investigate the impact of Jordan's flour fortification and the etiology of anemia in Jordan. Next, please. Regarding the household level finding, the Jordan National Micronutrient Annual Nutrition Status found a higher coverage of a bread made with a fortified flour than the 2010 survey when using a cut of 15 parts per million of iron. The median daily bread intake for the children from 12 to 59 months was 120 grams per day, and the median proportion of iron intake from the bread is 68. For the bread intake account, the bread intake accounts for almost 20% of recommended nutrient intake in a non-pregnant woman, and the median daily bread intake for the woman was 225 grams per day. Thank you.
Thank you very much, Engineer Rouhiya, for this rich and thought-provoking presentation. Um, as you saw, in Engineer Rouhiya highlighted that the change in vitamin A deficiency in preschool children from 2010 to 2019 may be attributable to the implementation of Jordan's vitamin A supplementation program. Moreover, she emphasized that the decline in anemia prevalence since 2010 may be linked to some extent to Jordan's wheat flour fortification program, and further research is needed to investigate the impact of the fortification program and the etiology of anemia in Jordan. Thank you again, Engineer Rouhiya. Our second speaker in this webinar is Dr. Asma Basha. Dr. Asma is the Director of Obstetric and Gynecology at the University of Jordan and the Jordan University Hospital. She is an obstetrician and gynecologist and one of the first to hold a feto-maternal subspecialty in Jordan after her training in Sydney, Australia. She is also the first female professor in OBGYN in Jordan. Currently, she is the Director of Obstetrics and Gynecology at the University of Jordan and the Jordan University Hospital. Her interests include sexual and reproductive health for women, with a special focus on pregnant and lactating women and fetal health. She has many publications in relation to these interests. Dr. Asma is a member of many committees in Jordan, including the Jordan Maternal Mortality Survey and Response, Caesarean Section Reduction Strategy for Reproductive Health in Jordan, Jordanian Board of Obstetrics and Gynecology, the Hashemite University Board of Trustees, Medical Accountability Committee, and others. Her ambition is to promote health equity for all. Dr. Asma, the floor is yours.
Thank you, Haneen. Good morning, good evening for everyone. And thank you for the coordinators for this webinar. I'm going to talk about causes and consequences of iron deficiency anemia among pregnant ladies. Next, please. Why iron is important during pregnancy? Because of the increased demand. The increased demands for the fetus and the placenta, for the increase in maternal red cell mass, and to compensate for the normal daily losses. Next, please. What is the definition of anemia or low hemoglobin? In pregnancy, below or up to 12 weeks, it's hemoglobin less than 11 grams per deciliter. And after that, it's after 28 weeks, it is less than 10 to 10.5 grams per deciliter. Next. So what happened during normal pregnancy? During normal pregnancy, the red cell mass will increase about 20 to 30%. The plasma volume will increase up to 50%. This will lead to what's called delusional anemia, which will peak at around 30 weeks of pregnancy. Also, the absorption of iron from the gut will rise, iron binding capacity will rise, and there is increased the synthesis of beta-1 globulin and transferrin. During normal pregnancy, the iron absorption will increase up to 40% from the ingested iron, while in normal person, it's 10% is the absorption rate. There is also increased reticulocyte counts, and serum iron concentration will fall. Next, please. To mention that ladies with multiple gestation, the demand will increase, and there is more drop in hemoglobin due to physiological anemia. Iron stores are diminished in 40% of women with multiple gestation, so that routine iron supplement is recommended, particularly to keep in mind the increased risk of postpartum hemorrhage, and this is increased risk of cesarean section rate. Next, please. When we do blood test for routine for women during antenatal care, from the routine investigation for these women is to do hemoglobin at booking, and it's advised to be repeated at 28 weeks gestation. When hemoglobin is low, it doesn't mean only that it is iron deficiency anemia. There is other causes of anemia in pregnancy, such as B12 deficiency, folic acid deficiency, hemoglobinopathies, other medical disease such as hemolytic anemia, and chronic disease such as autoimmune disease, infections, and malignancy. Also, we should keep in mind that combination of above causes can be present. So iron deficiency anemia is the commonest, and iron deficiency anemia is the commonest hematological problem in pregnancy. Next. What are the causes of iron deficiency anemia? It could be from diet, as improper diet, inability to have nutritious diet, or if the pregnant woman is vegetarian. It could be related to malabsorption disease, such as celiac disease, or if she had gastrectomy, bypass surgery due to previous obesity. Blood loss, if she had previous menorrhagia during her cycle, if she had bleeding peptic ulcer, if she had inflammatory bowel disease, if she had bleeding hemorrhoids, which is common during pregnancy, varices, if she's on aspirin, anticoagulant, or have congenital disease such as von Willebrand disease. Next, please. Also, some women will enter their pregnancy with depleted iron stores. It happened if she had previous recent pregnancy, if the distance between, or the interval between the recent pregnancy and the previous one is less than 1 year, and especially if she was lactating her baby in that previous pregnancy. Also, as I said, it's common in multiple pregnancies, and we have to keep in mind that there is blood loss, average blood loss after delivery. In normal delivery, normal vaginal delivery, it's about 500 cc, and in normal cesarean delivery, the average blood loss is around 800 cc. Next, please. What are the symptoms of anemia that a woman will come complaining of when she is pregnant? Usually, it's not non-specific at all. She can be complaining of tiredness, headache, faintness, dyspnea, palpitation, chest pain, angina, lethargy, dizziness, weakness, which is common presentation for different kind of diseases. And if she had an underlying cause, she might be present with the features of that underlying illness. Next, please. On examination, usually the patient, the mother will be pale. She might have brittle nail, angular stomitis, brittle hair, atrophy of the tongue papillae, tachycardia, murmur, signs of fetal heart failure, and signs of the other underlying diseases. Next. So, all pregnant women should be screened when they come for booking for hemoglobin. If hemoglobin is low, we need to investigate the cause of low hemoglobin. We need to do blood indices, a blood film, ferritin level, B12, folic acid level, hemoglobin electrophoresis, and to investigate for other chronic medical illnesses. Next. To mention that anemia in pregnancy is usually diagnosed on routine testing because the presentation usually is vague, and routine screening should be performed at booking visit and at 28 weeks gestation. Next. Why iron is important? Because for pregnancy and offsprings, because it affects all iron-dependent enzymes in each cell. It has profound effect on muscles and neurotransmitter activity. It is associated with low birth weight, preterm delivery, maternal infection, increased blood loss at delivery, poor fetal iron stores, increased placental fetal weight ratio, and in severe iron deficiency anemia, it is associated with increased maternal and perinatal morbidity and mortality. Next. So the management of iron deficiency anemia, what should we do? Management is prophylaxis, because prophylaxis is prevention. All women should be started on iron supplement during pregnancy. Usually we start after the first trimester, 30 to 60 milligram elemental iron. And we know all that absorption is maximized with fresh orange juice or vitamin C preparation. And we need to avoid inhibitors for absorption, such as coffee, tea, and chocolate when we take iron. Next. The WHO and International Nutritional Anemia Consultative Group and the United Nations Children Fund issued guidelines recommending routine supplement of 60 milligram per day iron and 400 microgram per day folic acid to all pregnant women for at least 6 months until 3 months postpartum in areas with high prevalence of anemia. Why during lactation also? Because the iron demand during lactation is important, because although the milk is white, but it contains a lot of iron. Next, please. What happened without iron supplement? Hemoglobin will fall, serum iron will fall, ferritin will fall, total iron binding capacity will increase. With iron supplement, hemoglobin is unchanged, serum iron is unchanged, ferritin is unchanged, total iron capacity increase, but to a little smaller degree. Next. Some women will avoid taking iron due to some gastric upset, such as nausea, vomiting, diarrhea, and constipation. So we need to encourage those women to take their iron, because anemia might be mild, moderate, severe, or very severe. Next. If the woman is not able to take iron because she's irritated or she's not compliant, we can advise her to take iron supplement every other day, or at least once per day. And also we can change the preparation. We have different iron preparation in the market. Some iron supplement will cause gastric irritations, others will not. So the woman had to try these. And also we have ampoules of iron, and we have parenteral iron if we need. If the iron is low, we need to increase the ingested dose of iron, which is 200 milligram per day of elemental iron. If more than 200 milligram will not produce supranormal hemoglobin. So the maximum dose is 200 milligram. If the mother is anemic near delivery, we cannot give her iron, oral iron or parenteral iron, because iron supplement will not increase hemoglobin more than 0.8 gram per week. So in this woman, we might go to blood transfusion, which we don't like unless we are in need. Next, please. This is what I have been talking before. Therapy failure is due to, if the mother is not compliant, might be due to malabsorption, and when the losses exceeds the intake, such as the presence of GI bleeding, hemorrhoids, etc. And most common, it's due, as I said, to poor compliance. If parenteral therapy is, if oral therapy is not efficient due to poor compliance, we can choose parenteral iron. Parenteral iron, it produces more compliant, but it doesn't produce faster response than oral iron. Next. So to remember that pregnancy causes 2 to 3-fold increase in the requirement of iron. Iron deficiency remains the commonest cause of anemia in pregnancy. Many women develop iron deficiency anemia because they enter pregnancy with depleted iron stores. Anemia in pregnancy is usually diagnosed on routine testing. Routine screening should be performed at the booking visit and at 28 weeks gestation. The best approach is prevention. It's not treatment, it's prevention. Prevention with oral iron supplement, at least in those at high risk of becoming anemic if the mother is not able or doesn't like iron supplement. The maximum rise in hemoglobin achievement with either oral or parenteral iron is only 0.8 gram per deciliter per week. Routine iron supplement is recommended, and especially in multiple gestation. Next. So, iron deficiency anemia remains the commonest, and iron deficiency anemia is the commonest hematological problem in pregnancy. Thank you.
Thank you, Dr. Asma. Thank you very much, Dr. Asma, for the comprehensive analysis of anemia in pregnant ladies. In summary, Dr. Asma pointed out that anemia is a major cause of maternal and neonatal morbidity and mortality, and iron deficiency remains the commonest hematological disease in pregnancy. It is easily preventable with simple measures like iron supplements. Thank you again, Dr. Asma. And now we will move to our last speaker, Dr. Nermeen Awad. Dr. Nermeen is the head of clinical nutrition and dietetics in the Hashemite University. She is an associate professor of nutrition and heads the clinical nutrition and dietetics department in the Faculty of Applied Medical Sciences at the Hashemite University in Zarqa. Dr. Al-Awad earned her PhD in 2012, her master's degree in 2004, and her bachelor degree in 2000 from the Department of Nutrition and Food Technology at the University of Jordan in Amman. She aims to spread science-based awareness in nutrition using various tools like research, nutrition education, and counseling. To date, Dr. Al-Awad has published 18 articles on several research topics, including functional foods, pediatric nutrition, sports nutrition, and dietary patterns associated with chronic diseases. Currently, she is a member of Health Education Clinic Committee at the Hashemite University and a member of the Technical Committee for preparing educational materials on complementary feeding and feeding diversity for children under 5 years old at the Ministry of Health. She is also a member of the Scientific Committee of the Jordan Dietetics Association and has participated in many local technical committees, including the Athletes Food and Food for Special Use committees at the Jordan Food and Drug Administration, as well as the Juice and Beverage Committee in the Jordanian Institute for Standardization and Metrology. Dr. Nermeen, the floor is yours.
Thank you, Haneen, for this introducing. And thank you for the webinar coordinators. I will talk about nutritional status and food consumption pattern for children and women of reproductive age in Jordan. Next, please. I will go through introduction, then under nutrition, indicators, overnutrition, infant and young child feeding practices, and food consumption patterns, and finally conclusion. Next, please. As you know, malnutrition represents the #1 risk factor in the global burden of disease, and the double burden of malnutrition is common worldwide and in the Eastern Mediterranean regions, and it's characterized by undernutrition and as well as overweight and obesity. Jordan is witnessing a nutrition transition, shifting towards a more westernized diet. Next, please. As you know, the faulty food consumption pattern may reflect the ongoing nutrition transition towards a more westernized diet, and this may contribute to the escalating burden of obesity, micronutrients deficiencies, and increase the risk of non-communicable diseases. Next, please. First of all, I will start with the undernutrition indicators, stunting, wasting, and underweight for children under 5 years old. As you see, the prevalence of these indicators was considered of low burden, and there is a decrease in the trends of these indicators. But for example, if we compare this with the World Health Assembly Global Nutrition Targets 2025 and 2030, for example, for wasting, we already achieved these targets because the wasting prevalence is less than 3%, and we have to keep this. But regarding the stunting, although there is a decrease in the prevalence, but we don't achieve the World Health Assembly Global Nutrition Targets, which mentioned that we have to decrease the annual rate for -3.9%, but here in Jordan, we achieve a -2.8%. Next, please. For undernutrition indicators, as you can see also, the low birth weight there is an increase in the trends between 1990 to 2080. And if we compare this with World Health Assembly Global Nutrition Targets, we don't reach this. So we have also to concern about low birth weight. Please, next. Okay. Regarding certain micronutrients deficiencies, I will talk just about anemia and vitamin D deficiency. Regarding anemia, children under 5 years old, based on Jordan Population Family Health Survey 2002 to 2070, the findings among 6 to 59-month-old children shows that anemia was stable until 2008. Then there is a slightly decrease in the trends, starting from 34% to 32% at the last survey. And regarding women of reproductive age, on the same survey, there is an increased trend, as you see, in the prevalence of anemia, starting from 26% versus 43% in the last survey. And if we compare this also with the global nutrition targets 2025, 2030, we do not reach the 50% reduction of anemia in the women of reproductive age, and also we have to concern about this. Next, please. Regarding vitamin D deficiency, the National Micronutrient Survey, as Engineer Rawhiya mentioned, that vitamin D deficiency was 19.8% and vitamin D insufficiency was 56.5%. Vitamin, also there's another observation that vitamin D deficiency was higher among females than males for 25.9% and 14%. This is for, I'm sorry, I don't mention children under 5 years. And another study conducted by Abdul Razzaq et al. In 2011 for preschool children in Erbil, which is a city in north of Jordan. The researcher found that the vitamin D deficiency was 28%, and also the author observed that female low sun exposure and exclusive breastfeeding were the main determinants of vitamin D levels. Next, please. Regarding vitamin D deficiency for the women of reproductive age, there was several studies were conducted in the and founded in the literature, and all of them conclude that there is a very high prevalence of vitamin D deficiency in Jordan. As one of the national representative study conducted by Al-Khatib et al., it was found that 88.6% for low vitamin D status, while 78.5% vitamin D deficiency among these age group or women of reproductive age. Next, please. Okay, regarding overweight and obesity, here, according to a model data between 2020, the trends in the prevalence of overweight and obesity among children under 5 years in Jordan was increased from 5.1 to 7.1. And if we compare this prevalence with the global nutrition target 2025 and 2030, we do not reach or achieve this target, because one of the target is, for example, to ensure that there is no increase in childhood overweight. The other one, to reduce and maintain childhood overweight to less than 3%. Next, please. Regarding the prevalence of overweight and obesity among Jordanian women of reproductive age, there is a lot of study that mentioned in the literature. For example, for the Department of Statistics on 2070, 2080, and also the stepwise approach to for non-communicable disease risk factor surveillance in 2080, it was found that the prevalence of overweight and obesity among Jordanian women of reproductive age was very high. And for example, in the STEPS survey, it was found that 40.4% of the women of reproductive age was obese, and 28.4% was overweight. Next, please. Okay, regarding infant and young child feeding practice, I will talk about a little bit about breastfeeding indicators. For example, if a breastfed, there is a slight decrease, although the majority of the infants was breastfed, for example, 81.7 in 2070, 2080. While early initiation of a breastfeeding, there is an overall increase by twofolds. For exclusive breastfeeding, there is an overall increase. It's stable since 2002, and only 26% of child between 0 to 6 months were exclusive breastfeeding, regarding to the 2070 survey. While continued breastfeeding, there is an overall decrease in the in this indicator. And if we compare the exclusive breastfeeding with the 2025 World Health Assembly Global Nutrition Target, we do not reach this target because it's called for at least 50% of the infants should be exclusively breastfeeding. Next, please. Regarding infants and young child feeding practices, complementary feeding indicators, here the introduction of solid, semi-solid, or soft food minimum acceptable diet, minimum diet diversity, minimum meal frequency. Each of those indicators showed a decreasing trend. Next, please. Okay, according to this study, which was conducted by El-Zahri et al. In 2070, which is a cross-sectional study to assess the nutritional status and estimate the prevalence rate of stunting, underweight, and wasting, and their associated factor among children under 5. The author concluded that low birth weight and mixed feeding, which is exclusive breastfeeding and formula feeding, were associated with higher rates of stunting and underweight in children less than 5 years old. Next, please. In another study conducted by Linda Shaker Pervary et al. In 2020, it was found that the following factors were associated with minimum dietary diversity, minimum meal frequency, and minimum acceptable diet at varied level. These factors are maternal factors, including maternal education and age, household level factors such as paternal education and wealth, community level factors such as culture and geographical location, and utilization of health services. Next, please. Okay, regarding consumption pattern, here, according to Jordanian Population Family Household Survey in 2070, as you can see from this figure, that except for fortified food, baby foods, all food items were highly consumed by non-breastfeeding than breastfed infants with the age from 6 to 23 months of age, while children at the age of 6 to 23 months of age were highly consumed to the food made from grains and cheese, yogurt, and other milk products, and less likely to consume food made from legumes and nuts. Next, please. Regarding food consumption pattern for women of reproductive age, the consumption pattern among women of reproductive age were assessed by limited cross-sectional studies in the literature and usually included in other studies, for example, that include male and female, and also the age group not specific for women of reproductive age. For example, in 2008, he conducted research for the age group between 19 to 70 years using 3 days food records, and he found that fruits, vegetable, meat, milk and dairy products, bread, rice, and pasta consumption as serving per day were less than the recommendation for this age groups, okay? But for example, if we take also the lifestyle practices for women in this research, for example, eat meals regularly, about 74.8% reported that they are irregular eat meals, and about those who eat breakfast, just 81.1% reported that 3 to 4 times per week they eat breakfast. And about how often do they eat fruits, just 37% reported that they are daily eat fruits. Next, please. Also, in another study that is conducted by Ministry of Health for STEPS, which is a stepwise approach for non-communicable disease risk factor surveillance in 2080, it was found that the fruits intake, the mean intake of this food group was 3 days per week, and it was approximately 0.8 survey per day. While vegetable, the mean intake was 5.9 days per week, and with the average 2 servings per day. And for the fruits and vegetable, around 85.7% reported that they eat less than 5 servings per day from fruits and vegetable, which is less than the recommendation of the WHO. It should be more than 5 servings per day. Regarding salt consumption, 33.6% of the women added salt when eating, while 80.5% of women added salt when cooking or preparing food. And there is a remarkable found that women at this age consumed about 9.7 grams of salt per day, which is reached the double of the WHO recommendation, which should be less than 5 grams per day of salt. Next, please. Also, in another study for women of reproductive age, lifestyle and eating data for Jordan University student, about 469 females aged between 70 to 30 years. By this study was conducted by Abu Sbeih et al. 2020. The number of meals eaten per day that reported for more than 3 meals per day was found to be 49%, while about 77.4% reported that the main meals is the lunch. Next, please. Here are one of the comprehensive review that conducted in 2022 by the Department of Clinical Nutrition and Dietetics in the Hashemite University with collaboration with an highly appreciated expert in nutrition from the WHO, Dr. Ayub Al-Jawaldi, and from the Ministry of Health, Engineer Rawhiya Barham. And this review was a very comprehensive review that if you want to know more than that I presented here for a nutrition situation in Jordan, and if you are interested in other age group, for example, adolescents or adult, you can find this in this review, which is published in Nutrients Journal. Next, please. In conclusion, the majority of Jordanian infants were not exclusively breastfed and do not continue breastfeeding for 2 years. Most children are introduced to complementary feeding at 6 months of age. However, a low percentage of those children meet the recommendation regarding the number of food groups, diversity, and timing. The prevalence of overweight and obesity among women was high and alarming. The national study assessing food consumption patterns are limited, especially for women of reproductive age. The paucity of data may be attributed to limited research funding and lack of coordination between different stakeholders. And thank you for listening. Thank you, Haneen. Here are
Thank you.
Thank you.
Yes, thank you very much, Dr. Nermeen, for your thorough presentation. I don't want to repeat what Dr. Nermeen said, like the points that she highlighted about the prevalence of overweight and the lack of national studies assessing food consumption, and I would move directly to the Q&A session. Yes, thank you. Okay, so the first question was for Engineer Rawhiya. In fact, I will compile 3 questions in one question for you. Those questions were about folic acid. One is asking about the comments on folate deficiency or folic acid deficiency. Although in Jordan we have rich food in folic acid, and the other is asking about strategies and public health measures to reduce micronutrients deficiencies, including anemia in women of reproductive age, and to enhance the nutritional status of both mothers and children moving forward. Engineer Rawhiya, the floor is yours.
Yeah, the first question regarding the folic acid, as Dr. Nermeen said before regarding the food consumption patterns, there's a transition in the nutrition. There's a nutrition transition from the traditional food to the Western food. This characterized by what we call it empty caloric food. rich or high in fat, high in sugars, but it's low in the micronutrients and vitamins. So for that, this is the one reason why we have a high folic acid and other micronutrient deficiencies. Among the most vulnerable group in Jordan is the preschool children, as well the pregnant, the woman in childbearing age. I have also the comment that in our micronutrient, National Micronutrient and Nutrition Status Survey 2010, we have also one indicator for the dietary diversity and supplement consumption. Actually, it revealed that 54% of the non-pregnant women had a minimum dietary diversity. This means that they are not follow the recommendation of a healthy diet by consuming the 5 food groups, at least 3 to 5 groups or items of vegetables and minerals, low consumption of meat. So this is this is a one main factor for the prevalence of micronutrient deficiency. As well, for the supplement consumption. For the micronutrient in general, like folic acid, B12, and iron was very low. The iron supplements were most widely consumed by this non-pregnant woman. Just by 15% of them they use in the last 3 months before conducting the survey the iron supplement. So also, they are not complying with the supplement. I take some comments from the Q&A. What are the steps later on for the flour fortification, although there is not a significant improvement? No. Actually, Jordan is considered as a success story for the WHO in implementing of the flour fortification program, and we shared this experience for many countries, Palestinian, Yugoslavia, as well Syria. Now we are working with Syria and Iraq. We have a significant improvement in anemia. And for the WHO, anemia is considered as a one indicator for improving the health status of the population. Actually, all the cases of the anemia was mild and moderate among the women in childbearing age, and it is we don't have a severe anemia cases in the children. This is one. Two, I think according to the data mentioned by Dr. Nermeen, and how the dietary diversity and the food consumption is transited from the traditional food to the Western food, I think the flour fortification program has an effective and functional benefits for the population, because this is the most vulnerable group. So any deficiency will be more clear in this target group. For the whole population, we have a good health status according to the main indicators of WHO, which is the anemia, vitamin A, and we saw the significant improvement. This is my comment for the 2 questions together.
Tamam, thank you very much, Engineer Rawhiya. Another question for you is, how does bread consumption compare to rice consumption in this country, and is rice among foods that are fortified in Jordan?
No, actually, when we fortified the food, we intend to fortify the stable food. In Jordan, when we make a focus group about the consumption of the food, we find that the bread and mainly the Komaj bread. If you notice that we concern about the Komaj bread because it's the main consumed bread among the Jordanian, and it is the staple food for all the Jordanian. The median consumption of bread among the Jordanian was 300 grams per day. They they eat it at every meal. So the rice maybe they are not consumed every meal, and it's not famous for some families. So in the protocol of fortification of the food, we intend to fortify the stable food, and bread is the stable food of Jordanian. For Indian, for example, the main staple food for them is the rice. So they intend to fortify the rice for the population of India.
Yeah. Tamam. Thank you, Engineer Rouhia. Another question for all speakers. What public health measures are in place would you recommend to address anemia in women of reproductive age group? Dr. Asma or
Yes,
Engineer
okay.
Rouhia, feel free. Yeah.
We can focus for prenatal counseling. If a woman is wishing to get pregnant, she had to see her physician before, and routine testing should include hemoglobin and ferritin, in addition to folate, B12 if it was in need. If it is low, she should have iron supplement before she is pregnant. This is my answer. Prenatal care, proper prenatal care. In addition to when she's pregnant, to do the routine investigations.
Yeah. Thank you, Dr. Asma. Another question, is there data on the percentage of stunting, wasting, and underweight children under the age of 5 in Jordan? If so, what is Jordan's Ministry of Health strategy for dealing with such cases?
I will answer this question because I present all the indicators of malnutrition in the preschool children. Actually, Jordan has achieved a progress in combating the malnutrition among the school children below or under 5 years. As we say, regarding the wasting, Jordan is considered as one of the countries of the IMRO with no problem of wasting. It's less than 1%. Regarding the underweight, also there's a significant reduction to the half from 2010 to 2019. So it's normal. As well, for the stunting is considered as a mild public health problem, and there's a significant improvement as well. The main problem actually for the children is the obesity and overweight. As any country, we are go with this problem. We don't have increase, but it is remain unchanged. So all the data regarding the malnutrition is available in the report of the National Micronutrient and Nutrition Status for the Jordanian and Syrian refugees that published on the website of the Ministry of Health. So we don't have any a problem regarding the malnutrition. Just for the obesity, regarding the woman in childbearing age, which is classified as a severe public health problem.
Thank you, Engineer Rouhia. That will lead us to another question. Do we have any information on obesity and overweight trends for children from 5 to 15 years old?
Okay, Haneen, I will answer this question. Yes, we have, and in the review that I mentioned here, we can see that overweight for 6 to 17 years old children and adolescents was 17.3%, and for the obesity was 15.7%. This is the last data that was published in the WHO website.
Great, thank you, Dr. Nermeen.
Thank you.
The last question is back to you, Engineer Rawhiya. What would you suggest as an urgent need to study in Jordan among children's nutritional health status?
Actually, every 5 to 10 years, we conduct this micronutrient and nutrition status for the most vulnerable group in Jordan is the preschool children and the women in childbearing age. And this survey 2019, we have other key groups is the school children from 6 to 12 because they're suffering from obesity and some vitamin deficiency, vitamin D deficiency. So we are already conduct this cross-sectional survey every 5 to 10 years, depend on the funding and sponsor of this survey.
Okay, so what? So the urgent need to study now in Jordan among children nutrition status would be to also continue. You mean the monitoring
Yes.
Studies that Ministry of Health is doing?
Yes, mainly for the obesity and other deficiencies of vitamins like vitamin D deficiency, because in this survey also we have another indicator is the sun exposures for the preschool children in the city population. This indicator is very low, and exposed to the sun was very low among the preschool children and the school age children in the city population, comparing with this factor among the Syrian refugees. So the deficiency of vitamin D is less than among these school children and preschool children in Syrian refugees than the Jordanian, due to the high exposure to the sun. So we have many indicators that we should investigate later on, like the iron deficiency, as well the vitamin D among the preschool children. For the woman, it's folic acid and vitamin B12 and iron deficiency anemia. For folic acid, in the beginning of the program, we recommended to add it in 1.5 part per million, but the higher committee of nutrition suggests that we don't have any sign or diagnosis of folic acid deficiency. So it's better to reduce the rate of addition to 1%, 1 part per million. So now we can take a decision with the higher committee and expert to raise the level of addition of folic acid to 1.5 according to the recommendation of WHO. So we have many recommendations and we have many suggestions regarding these indicators.
Thank you very much, Engineer Rawhiya, for the comprehensive explanation and clarification. I have another question for Dr. Asma. So as you know, the iron supplement is the main treatment for anemia. How can we convince women to comply with taking their iron supplements?
We can convince them that it is important for their health as their infants. So iron is not for her baby only, it's for her health, for her skin, for her hair, for her well-being, etc. Usually I talk to them, iron is important. It's not for the baby, it's for you, because the baby is a kind of selfishness. It will take whatever he needs from the mother, and the mother will be depleted, and she will not be able to follow him, to care for him, to have another babies, and to be in a good health. So I go for her health, for her future, for her skin, for her hair, for her well-being, etc. So they will take it.
Yes, thank you, Dr. Asma.
And for her beauty in a kind of or another.
Yes, of course. And what is the difference between oral and IV iron?
Usually, as I said, the increase of level of hemoglobin per week, it will be 0.8 gram per deciliter. Parenteral iron will prevent the GI disturbances. We will go out of the compliance. So she will take it once every, say, 4-6 weeks, and she doesn't need to remember the iron supplement or to suffer from its side effects. So it's more convenient for women who are not compliant or who suffer from GI disturbances. Yes.
Yes, thank you, Dr. Asma. The last question for Dr. Nermeen. What are the reasons for escalating rates of overweight and obesity among women, and how can we control that?
Okay, thank you, Haneen. As you know, and as Engineer Rawhiya mentioned, there is a high consumption of energy and sugar-sweetened beverages, and also processed food, less consumption of fruits and vegetables, and also for the sedentary lifestyle. These are the causes for the high prevalence of obesity and overweight. And we have a lot of issues that can we control obesity. For example, for the food consumption pattern, we have to increase the education tools through, for example, social media and other facilities that can reach for a large number of person or people, especially women of reproductive age, and also from the women's and child health centers from the that is under control of Ministry of Health, can be, for example, give more education for this age group. Thank you.
Great, thank you very much, Dr. Nermeen. Yeah, that was the last question. Thank you very much. In conclusion, I would like to thank our esteemed speakers for their nuanced presentations, and to thank you all for attending the webinar. I want to remind you that the recorded webinar will be shared on our website soon. And we encourage you to remain engaged in future JNIL activities by exploring our website and social media pages. I will be pasting the links for our pages in the chat box right away. Yeah. Thank you very much. Over to you, Shibani.
Thank you, Haneen, very much. And thank you all for joining us today for a very important webinar. Presentations that have been made by all our panelists have really highlighted what the policy actions that are ongoing in Jordan, as well as what are the clinical and public health considerations ensuring and supporting optimal health and nutrition of women of reproductive age, their infants and their young children in Jordan. As Engineer Rawhiya has noted, there are clearly areas of progress, for example, with the Flower Fortification Initiative reaching a significant proportion of the population, but there are clearly areas of concern. Whether you're looking at iron deficiency in the women and or the increasing prevalence of overweight and obesity in both population subgroups. The issue of the importance of iron has also been very clearly articulated by Dr. Asma. I think what really surprised me was to see the increasing folate and B12 deficiencies. And I know this is not a public health concern within the context of the numbers we're doing, but at the clinical level, as we know, folate is a very critical nutrient and needs to be received by women of reproductive age pre-conception. So this is something that maybe we want to think about a little bit more from a clinical and a research perspective. But clearly, there is national data that is generated on a regular basis, and the government of Jordan tracks progress on how Jordan is tracking along these public health indicators. There is need, based on Dr. Narmeen's presentation, that we need to really assess food consumption patterns at the national level, and there's need to understand the dietary patterns of both Jordanian women and children so that we can determine the factors that lead to those poor dietary practices. As noted by Dr. Narmeen, there's also a need for concerted effort to allocate resources towards not just conducting national surveys, but also to support research in this space, particularly from my perspective, testing interventions to support better diets and health in women and children. That's just one example. But what is clear to me when I've listened to this webinar is that despite these challenges, there is a committed group of researchers, implementers, and policymakers in Jordan for whom ensuring maternal and infant nutrition in Jordan is an extremely high priority. With that, I'd like to really thank our esteemed panelists for presenting such a riveting and relevant set of presentations. And thank you all for joining us and engaging in a vibrant discussion. For those of you who are still with us right now, please note that we do have a second webinar scheduled this week. It's titled A Closer Look on the Ground, Breastfeeding Practices, Benefits, and Challenges. This is scheduled for 2 p.m. Amman time on September 29th, and we'll continue the discussions that JNIL is engaging in around maternal and infant health and nutrition. I do hope you can join us for that webinar as well, and please have a good day, everybody. Thank you so much.